Okay, so let's get into some drugs that target cardiovascular diseases. One such cardiovascular disease that we're going to be looking at is dyslipidemia. Dyslipidemia refers to abnormal levels of lipids or fats in blood, specifically cholesterol. And so, one of the three main drug classes used to treat dyslipidemia, and in fact is the main class used to treat dyslipidemia, includes statins, also known as HMG-CoA reductase inhibitors. So, statins such as atorvastatin or rosuvastatin work primarily in your liver to lower bad cholesterol or LDL or low density lipoprotein and reduce plaque buildup in your arteries. That's the key feature of this drug. And it achieves this by inhibiting a particular enzyme expressed in the liver called HMG-CoA reductase, which is an enzyme that is critical for cholesterol synthesis. So we can see here in this mechanism of this cholesterol biosynthesis mechanism, this happens within the liver cell or the hepatocyte, where acetyl-CoA is converted to HMG-CoA, which is then converted to mevalonic acid through HMG-CoA reductase, which is the key molecular target of statins. When this happens, it goes through another series of steps which eventually yield cholesterol. So the idea is to prevent the synthesis of cholesterol by inhibiting this particular enzyme. So by inhibiting this particular enzyme, less cholesterol is synthesized, thus lowering the patient's chances of experiencing a heart attack or stroke caused by atherosclerosis or plaque buildup in the arteries. Now, in terms of taking these medications, in terms of looking at how the patient should take this medication, some administration tips include that the medication can be taken at any time of day. Many prescribers usually prefer evening dosing, but it's not essential for statins in general because it's been shown in studies that there is no significant difference in nighttime or day dosing in general for statins, but some statins work differently. The medication can be taken with or without food. Simvastatin and lovastatin are the special exceptions to the rule of being taken at any time of day. They're often preferred to be taken in the evening because they have a shorter half-life. So the reason why the medication is taken in the evening for simvastatin and lovastatin is because when a person has a heavy meal that's high in fats, the medication will work more efficiently in the evening when it's taken closer to the meal. And this is important to consider, especially when it has a shorter half-life, meaning it will have a shorter duration of action. So this is why these two statins are important to take in the evening, because they have a shorter half-life. In terms of missed dose, if a dose is missed, the patient should remember to take it. The patient should try to take it as soon as they remember, unless it's more than halfway to the time for the next dose. So if it's close to the next dose, you just want to skip the dose and resume the usual dose schedule at the next dose. In terms of dosing, atorvastatin and rosuvastatin have dosing regimens based on the intensity of the statin regimen. So for medium intensity dosing, for atorvastatin, you want to take 10 to 20 milligrams once daily, and then for high intensity dosing for atorvastatin, the patient takes a dose between 40 to 80 milligrams once daily. For rosuvastatin, the medium intensity dosing regimen is between 5 to 10 milligrams once daily, and then for high intensity dosing, it's 20 to 40 milligrams once daily. Some side effect profile of statins. So most people generally tolerate statins well, and serious muscle or liver problems are rare. The most common side effects of statins include mild muscle aches and joint pain. Other side effects could also include stomach upset or nausea or headache. These side effects are usually mild, but the patient should contact their doctor if the side effects persist or become unbearable. Now, the main red flags of this medication, which warrants a doctor consult or immediate emergency help or medical help, include unbearable muscle pain or weakness accompanied with dark urine, which may be a sign of rhabdomyolysis or a lead up to rhabdomyolysis. The other side effect includes liver issues or hepatotoxicity, where the symptoms may manifest as unusual tiredness, loss of appetite, dark urine, yellowing of skin of the eyes, rare, and these side effects are rare but important to mention. Some other side effects include, in terms of the interactions of this medication, statins have huge potential to interact with other medications given it's a major CYP3A4 substrate. This means that the medication is cleared by the liver, and so the most important most important substances that patients want to be mindful about is alcohol consumption, and then certain antibiotics, antifungals, HIV meds, and then grapefruit juice. So the big two that we really want to be worried about are alcohol and grapefruit juice. So we want to limit alcohol or avoid large amounts of grapefruit juice, as these can increase the levels of statins or decrease the clearance of statins from the body, since the body clears statins mainly through the liver. Okay. In terms of storage temperature, we want to, in terms of storing the medication, statins can be stored at room temperature, dry place, kept away from moisture and light, and of course away from children. Some non-pharmacological or non-drug measures that the patient can take to help manage the dyslipidemia is consuming a heart-healthy diet, where they consume they reduce the amount of saturated trans fat intake. They also increase their fiber intake. They also want to make sure that they get regular exercise, approximately 150 minutes per week if possible, and they want to make sure they're managing their weight appropriately, and then stopping smoking or vaping if possible, as well as managing their blood pressure and diabetes. Some adherence tips to the medication is that this is a long-term, we want to emphasize to the patient that this is a long-term prevention medication, not for feeling better right away. We want to make sure that the patient takes the medication at the same time, or we want to remind the patient to take the medication at the same time every day to help with remembering to take the medication, which may help improve adherence. We can tell the patient to set phone reminders or link the habit of taking a medication to an existing routine to help, again, with adherence. In terms of monitoring follow-up, in terms of measuring the efficacy of the medication, the healthcare professional will usually order a lipid panel or a cholesterol panel, which measures the levels of cholesterol in blood, and then that should be checked prior to initiating therapy to establish a baseline comparator, and then every couple of months, usually 3 months, to see a response. In terms of safety, we want to monitor for, again, the side effects. So if the patient is experiencing muscle aches that are muscle-like and are persistent or don't go away, that's a sign that the patient needs to get a reassessment from the doctor. And if they're not sure if the pain is coming from the statin or it's another cause, again, you want to consult with the doctor to get an assessment. We also sometimes may want to check liver enzymes if the patient is presenting with symptoms of hepatotoxicity. And as for pregnancy or breastfeeding considerations, we want to consider avoiding or discontinuing the medication when pregnancy is recognized, as there is a potential to cause harm to the fetus. Alternatively, if the medication is still deemed necessary during pregnancy, the patient can switch to a hydrophilic option such as pravastatin or rosuvastatin. And then the same principle applies for breastfeeding, because the medication does lower cholesterol. So by decreasing the amount of cholesterol available when the patient is breastfeeding, the infant cannot develop properly. So from the bottom line is that cholesterol in breast milk is required for infant development. That's why it's important to either avoid or discontinue this medication. So Ezetimibe is used as an adjunct therapy mainly, but it can also be used as monotherapy if the side effects of statins are not tolerable. Okay, so the mechanism of action here is that it works to lower blood or bad cholesterol or LDL, and to reduce plaque buildup in your arteries. And it achieves this by blocking a particular cholesterol transporter protein called NPHT C1L1, which is a cholesterol transporter expressed in the brush border of the small intestine. By doing this, it also works to lower lower the patient's chances of experiencing a heart attack and stroke. Now, the directions on how to take this medication. Again, same thing as statins. It can be taken at any time of day, taken with or without food. And then as for the missed dose, same thing. If you miss the dose, just take it as soon as remembered, unless it's more than halfway to the time for the next dose. Then, in that case, if it's more than halfway to the time for the next dose, just miss the dose. Resume the usual dose schedule at the next dose. Dosing, the standard dose is 10 milligrams once daily, regardless of the condition, typically. The side effects are similar, where the patient may experience mild muscle aches or joint pain, as well as signs of a common cold, usually malaise, like feeling tired or weak. But again, if the patient happens to be experiencing unbearable muscle pain or weakness accompanied with dark colored urine, which is again a sign of rhabdomyolysis or lead up, the patient should seek medical help immediately. So you also want to monitor for hepatotoxicity. Interactions. I think the biggest interaction that we want to watch out for are patients on bile acid sequestrants such as cholestyramine, cholestipol, or colesevelam, which can reduce ezetimibe absorption. So to mitigate this, the chances of these medications interacting, we want to take ezetimibe at least 2 hours before or at least 4 hours after taking bile acid sequestrants. Another interaction involves fibrates, where taking fenofibrate along with ezetimibe can increase the risk of gallstones. And then lastly, the last major interaction that we want to watch out for is warfarin and ezetimibe taken together, where additional INR monitoring is recommended. In terms of storage, same thing. Non-farms, same thing. Adherence tips, again, the same thing. And then monitoring, same thing. Pregnancy, for breastfeeding considerations, we want to consider avoiding or discontinuing for both cases, because again, in terms of breastfeeding, cholesterol in breast milk is required for infant development, and by using this medication you lower cholesterol absorption, so you minimize the amount of cholesterol available to be delivered to the infant. So to mitigate this, we want to consider avoiding or discontinuing this medication. Again, weighing out the benefits to taking this medication against the risks of experiencing side effects while on this medication. So we're going to be moving on to the last class of medications last main class of medications used to treat dyslipidemia dyslipidemia, and they include PCSK9 inhibitors. Such inhibitors involve monoclonal antibodies such as alirocumab and evolocumab. So, as I've said, they're monoclonal antibodies that work in your liver to lower low-density lipoprotein levels, or lower low-density lipoprotein cholesterol levels, and reduce plaque buildup in your arteries. And it achieves this by inhibiting a particular enzyme expressed in the liver called PCSK9. So, what PCSK9 is a regular protein that, once bound to low-density lipoprotein receptors, which normally work to uptake cholesterol from the blood and lower blood cholesterol levels. Once PCSK9 is active and binds to LDL receptors, it promotes LDL receptor internalization within the liver or the hepatocyte, and degradation. So this means that fewer low-density lipoprotein receptors on the hepatocyte surface can contribute to the clearance of low-density lipoprotein cholesterol from the bloodstream, which results in increase in low-density lipoprotein cholesterol in the blood. But in the case of when using PCSK9 inhibitors, you actually allow for more low-density lipoprotein receptors to stay on the hepatocyte surface, which results in more clearance of low-density lipoprotein cholesterol from the bloodstream. and this will cause a decrease in low density lipoprotein cholesterol in the blood. So essentially, we have an increase in low density lipoprotein clearance, especially when this medication is combined with statins. So by doing this, the medication works to lower your chances of experiencing a heart attack and stroke, just like with the other dyslipidemia drugs that we talked about previously. So in terms of directions on how to take this medication is administered by injection subcutaneously, and it can be administered into 3 areas, including the thigh, abdomen, and upper arm. When injecting the medication each time, you want to rotate injection sites to maintain the efficacy of the medication. You don't want to inject into undesirable sites of skin containing features such as being tender or the skin being bruised, hard, or red hot, or with damage. And then we also want to avoid reusing pre-filled pens or syringes as they're intended for single use only. Now, in terms of dosing, the alirocumab dosing schedule. Note that this medication is primarily ideal for patients who have a history of hypercholesterolemia. So in the case of heterozygous familial hypercholesterolemia, the dosing regimen is 150 milligrams subcutaneous every 4 weeks, with adjusting to 75 milligrams subcutaneously every 2 weeks if the response is inadequate. Same thing with homozygous familial hypercholesterolemia. The initial dosing regimen is 150 milligrams subcutaneously every 4 weeks, with the maintenance adjusting to 75 milligrams subcutaneously every 2 weeks if the response is inadequate. In evolocumab dosing, it's a bit of the same thing. It's 140 milligrams every 2 weeks, or 420 milligrams once monthly. And then for familial hypercholesterolemia, for heterozygous hypercholesterolemia, it's 140 milligrams subcutaneously every 2 weeks, or 420 milligrams once monthly. And then for homozygous, it's 420 milligrams once monthly, which may include to an increase to 420 milligrams once every 2 weeks if the response is inadequate. Now, in terms of missing the dose, for every 2-week dosing, if missed doses within 7 days from the patient's original schedule, we want to administer the dose and resume the original schedule. But if the missed dose is more than 7 days from the patient's original schedule, we wait until the next dose on the original schedule. And then for every 4-week dosing, if the missed dose is within 7 days from the patient's original schedule, administer the dose and resume the original schedule. But if the missed dose is more than 7 days from the patient's original schedule, administer the dose and start a new 4-week schedule based on the new dose. Now, some side effects include that the medication can cause mild muscle aches and joint pain, so pain, redness, or swelling at the injection site, or a headache. But the big major red flag is that the patient should seek a doctor immediately if there's signs of an allergy reaction, such as difficulty breathing or developing a rash. Interactions, generally very minimal. Storage, you want to store this in the fridge. And then for non-pharm measures, you want to do the same thing. In terms of adherence tips, just try to remember to take the medication at the same time when possible, and set a reminder. Setting a reminder will probably be the biggest tip. Setting a reminder, alarm, phone reminder is key. And in terms of monitoring, cholesterol panel, and then maybe not liver enzymes. Maybe it would be just follow up if muscle aches or muscle ache and don't go away. And then in terms of pregnancy or breastfeeding considerations, you want to consider avoiding or discontinuing. The safety data isn't clear for pregnancy or breastfeeding individuals, so just caution use, essentially.